multi-payer primary. Thank you, Sam. We have our people joining us for a really exciting meeting today, a combination of updates and announcements, and then a special presentation from colleagues at Georgetown who have been writing some very important studies around primary care access. So please sit tight. We're just waiting for folks to sign in, and we will get started in just a few minutes. In the meantime, while we're just waiting for everyone to be able to be admitted from the waiting room, if I could prevail upon you, there are quite a few people whose names I don't actually recognize, and I'm delighted for that because I think we perhaps got a little more exposure than we normally do because of our colleagues at Georgetown joining us. If you wouldn't mind just putting your name and your organization into the chat, if you're dialed in using your computer, just so we know who's on while we're waiting. Thank you very much. Well, for those of you just joining us, you are at the Milbank Memorial Fund Multi-Payer Primary Care Network Advisory Group meeting. These events happen each month, and we're delighted to have some special guests with us today for a presentation about a very important series of papers being written around primary care access. So we'll get started in about 1 minute or so. And if you're just joining us, if you wouldn't mind just popping your name and your organization into the chat so we can all see who's here. Okay, I think I'm going to start the meeting. Thanks everyone for joining us. This is a very exciting opportunity for us to have a really new and exciting shared learning opportunity. I'm just going to walk through the agenda and just make sure that we have, and obviously if people have something else they want to add, I'm happy to do that in our announcement section or at the very end of the meeting. First of all, we have our, just reviewing the agenda, we're going to do a series of announcements and updates, and we have a little bit of detail around the request for information that came out from HHS last week. So we'll be talking about that in some detail. Then really for the bulk of our time together, we have a special presentation on the effectiveness of policies to improve primary care access for underserved populations. An extremely timely presentation given our global concern about access to primary care and health equity. And our main authors, Maanasa Kona and Megan Houston, are here with two of their colleagues that they will introduce from the Georgetown University Health Policy Institute. And they'll be presenting the results of their white paper that was published by Milbank earlier this year, as well as they're creating a set of case studies. So we're very excited about that. And there'll be an opportunity for some question and answers at the end of their presentation. Anybody have anything they wanted to add to the agenda as long as we're here today together? Okay, great. Well, with that, I would like to just also announce that I am actually away from my normal area of work. I'm on holiday for this week, and my friend and colleague, Ken Rogers, who is the experienced and skillful convener of the primary care work being done on behalf of the CPC Plus initially, and now Primary Care First, in the Western New York area in Buffalo. He is going to be facilitating the question and answer session at the end of the hour today. I'm going to stay on for as long as I can, but thank you, Ken, in advance for all your help. So with that, I wanted to talk a little bit about this RFI that came out, I think it was last week. And if Diane Beekle-Marriott is on the line, I'm not sure if she's here today, but if she's with us, I just want to shout out to her. She's been very active in trying to create some momentum for answering the request for the information that HHS has put out on behalf of a collaborative in Michigan. But the Office of the Assistant Secretary for Health is coordinating development of an initial HHS action plan to strengthen primary health care. They released this RFI seeking input from members of the public about what the federal government could do to strengthen primary health care in the US. And in particular, they're looking for ideas about innovations, models, solutions to barriers, and possible HHS actions that can strengthen primary care to promote health equity, reduce health disparities, and improve healthcare access and health outcomes. Responses to the RFI have to be submitted by August 1st, and there is a 4-page limit. So none of those mighty tomes that we might want to submit. At Milbank, we think that certainly using the NASM recommendations for what high quality primary care and the steps leading to that should be, seems like an excellent framework for a response, but certainly encourage any of you that are interested in making your voice heard. It seems like a great opportunity. It's a pretty tight turnaround in terms of the timeline, as I said, August 1st being the deadline. And I just wanted to share what Diane Marriott had put together for her group in Michigan. And they had a couple of points in their response that is still being drafted. The first is to provide payers and plans who participate in multi-payer collaboration with advanced briefings about the direction that CMS will be taking on important issues, including social determinants of health capture, such as continued utilization of Z codes or interoperable referrals, et cetera. Greater clarification regarding expectations for SOGI or REAL data collection, as in field standardization, prospective attribution in terms of methodology and calculation of hybrid payment for primary care, such a combination of partial capitation incentives and fee-for-service components, aligning quality, patient experience, patient outcomes, and utilization measures across federal programs, decreasing barriers for practices, about chronic care management and complex chronic care management codes, and rebalancing RVUs to better reward primary care. So those are the points that the group in Michigan has determined that they want to emphasize, but there are plenty of others. And I just wanted to offer that as a starting point for if you're thinking about this. I understand there's also a group in Rhode Island that is doing something similar to what they're working on in Michigan. And if anyone else has any insights into this or things they want to share with the group, I'd be delighted to hear that.
Yeah, hi, Lisa. This is Deb from Rhode Island. So,
hi, Deb.
Hi. So, yeah, we do plan to respond by the August 1st deadline. So it's great to hear, and anybody who wants to is willing to share their, outline. That's sort of my next task after this meeting is to sit down and start to rough out the outline for what we want to say in each of the 4, I think it's 3 or 4 question areas that they posed. And so, yeah, we think it's important, and certainly are using the NASM report as kind of a guide, and also the PCC concordance recommendations, which also I think ties nicely to the NASM report.
Great, thank you. I'm going to put the link in chat so everyone can, if you haven't already had it. Thank you, Deb.
Yeah, and I just want to thank Diane Marriott too for sharing her letter to Admiral Levine and the letter template and whatnot. So we did send that off as well. I think the timing was such that they probably got our letter as the RFI was coming out. So they just thanked us and said, could you please respond to the RFI? And that was fine. So, but at least they heard.
Well, that's great. I think it actually makes a big difference. And there are people who are very active in this work. Many of have either met or are familiar with Bob Phillips, and really trying to garner just make it a lot of noise, especially coming from multiple different states. I don't think it's possible to have a unified state response for every state, for every RFI. But I think that if there can be representation of a wide swath, I think that would really make a big difference. And this group has tremendous that we are in right now has tremendous potential for really sharing now collective hundreds of years of collective experience. And if we're looking at the last 10, where a lot of work has been done in multiple multi-payer programs focused on primary care and demonstration of improvements in a lot of ways. So there's an openness on the part of the current administration to listen to that, and those channels can be more formal as this RFI is, but I think letters are also, frankly, there's no reason not to do this. So I'm glad you're able to.
Right.
Anyone else have any comments or questions? Okay, great. All right, well, with that, Sam, I'll have you stop sharing, and Emma, I guess I'll pull up your screen and I will turn it over to our colleagues from Georgetown.
Great. Hi, everyone. Let me just share my screen.
Thank you, Emma. And thank you, Lisa. As Lisa mentioned, I'm Maanasa Kona, an assistant research professor at Georgetown University's Center on Health Insurance Reforms, and I'm joined today by my fellow researchers and colleagues on this project. There's Megan Houston, who'll be presenting with me, and I'm also joined by my two other colleagues, Jaleesa Clark and Emma Walsh-Alker, who will be more active in the chat and responding to any questions that might come up there. Next slide. For those who might be unfamiliar, I just want to kick off with a brief introduction to our center. So we're essentially a think tank that is part of the Georgetown's McCourt School of Public Policy. Our center conducts legal and policy analysis related to the health insurance industry, and we look both into federal and state regulation of the industry as well as market trends. We publish our research in a variety of reports and briefs and blog posts, et cetera, and we also rely on this research to provide technical assistance to a variety of state and federal policymakers. Next slide. So today we're going to present our findings from an ongoing project that we kicked off in May 2021, and we're partnered with Milbank for it, and we've been very grateful for their collaboration. This project has been funded by the National Institute for Healthcare Reform, and it looks into ways to improve access to primary care, particularly for underserved populations. For the purposes of kind of limiting the scope of this project, we specifically limited it to questions about access and not quality or outcomes or cost. And even with that, I mean, this project was a bit of a bear, and as you'll see, we had to follow the lead in many different directions. Just wanted to let you know that the scope was limited to access issues. More specifically, we went in trying to understand how well the different types of initiatives, programs and policies that seek to improve access are actually working on the ground. For the purposes of this project, we primarily focus on the following types of underserved populations, mostly low income, Medicaid eligible, uninsured populations, racial and ethnic minority populations, as well as those living in rural areas. So as part of this project, we first published literature review in January this year. And in that review, we identified a number of different types of policy initiatives and then reviewed the research literature and the gray literature to kind of understand how these initiatives have been working, what's out there, what's been published. We then distilled this over 70-page report into more bite-sized chunks and published about 5 fact sheets. All of these are available on the Milbank website, and I'm sure Lisa can share the links to all of our published works with you if you would like them. And now we're in the midst of conducting 5 case studies in locations around America to better understand sort of on the ground issues and any successes. So to inform each case study, we talked to local leaders, state and local agency officials, local primary care providers, FQHCs, hospitals, patient advocates to kind of get a good sense of what's been effective, what hasn't. We've already published our first case study. It was set in Grant County, New Mexico, which is a rural area with a high Hispanic population. We also recently wrapped up our second case study in Baltimore City, Maryland, and that case study is still in review and is upcoming shortly. And interviews are now underway for our third case study, which is set in Columbia County, Arkansas. I noticed that there's some people on this call from Arkansas. Please feel free to reach out to me and my team if you would like to participate or learn more about our case study there. As for our final 2 case studies, one will be set in a rural area and another one in urban underserved areas, TBD. Next slide, please. So to help orient ourselves and our readers, we loosely relied on a model of access and a definition of access that was developed by researchers Penchansky and Thomas in the 1980s. They defined concept of access based on 5 A's, and the policy initiatives we consider kind of loosely categorize themselves into these 5 A's. The first A is about the availability or supply of clinicians, whether it's physicians or NPs or PAs. Categorized under this bucket are any sort of workforce type policy initiatives to improve recruitment and retention of primary care providers in underserved areas. The second A is accessibility in terms of geography. We look at policy initiatives that address things like transportation barriers, improving access to telehealth, bringing more safety net outpatient clinics into the communities. The third A is accommodation. And then here we look at how patients, how providers accept and see their patients, including hours of operation. The fourth A is affordability. So we look at policy initiatives that improved insurance enrollment, reduced out-of-pocket costs. And finally, the fifth A is acceptability. So during our research, we kind of quickly realized that merely being able to make and keep primary care appointments and pay for them is insufficient when patients feel unheard and cannot trust or communicate freely with their providers. And so under this bucket, we kind of looked at some initiatives that are trying to improve this trust and this relationship between providers and the communities they serve, because we find that these efforts are critical in terms of fully establishing access. So as I mentioned earlier, we use these categories loosely, and in our various papers, information has been reorganized, and some of them categories have merged and further broken down. But at every stage, we did make sure that we're paying attention to all of these different components of access. Next slide. So to kick off our discussion with policy, we'll kick it off with policy initiatives that target the supply of primary care clinicians. So the AAMC, the Association of American Medical Colleges, forecasts a potential total shortfall of 20,000 to 55,000 US primary care physicians by 2033. And since 2011, the number of US trained medical students who choose primary care residencies has declined. Evidence has suggested that some medical students view the lower income potential of a primary care career compared to other specialties as a barrier to choosing a primary care career. So at the federal level, we've tried to increase reimbursement for primary care a couple of different times to make it perhaps more lucrative. First, the ACA did the Medicaid fee bump. They increased Medicaid reimbursement rates for primary care services to match Medicare rates in 2013 and 2014. This did result in a 73% average increase in Medicaid reimbursement for primary care services. And then in 2020, CMS substantially increased Medicare reimbursement rates for primary care for the first time since the 1990s, while cutting rates for specialties. So when the question comes to whether these did work in making primary care a more attractive field for medical students, the short answer is it's too soon to tell. The ACA Medicaid fee bump was only temporary, as you might be aware, and then the 2020 Medicare fee increases were just too recent to assess this kind of long-term impact, and we think that this is an area that researchers should keep an eye on in the future. Next slide. So about 20 years ago, the federal government, which funds residency positions through the Medicare program, capped the number of positions. And the federal efforts to increase this number have been mostly insufficient, according to what we've seen in our research. But a number of states did step up to create more residency spots, particularly in primary care and in underserved areas. So for example, New Mexico leveraged some federal Medicaid funding to develop additional primary care residencies in underserved locations across the state. Texas and Georgia legislatures appropriate money to support the creation of new residency programs, particularly for primary care and in geographic areas that lack existing programs. On the question of whether these efforts have paid off, the short answer is yes. New Mexico's efforts created 10 primary care residency slots in high need areas, which I realize is a modest number, but in a sparsely populated rural state with significant workforce shortages, it's still an important development. And we'll discuss a little bit more about New Mexico's efforts when we discuss our case study in a little while. As for Texas, a 2019 report evaluating its new programs found that they'd created almost 400 new residency positions. And in Georgia, as of 2018, 64% of the new residency positions were located in federally designated health professional shortage areas. Next slide. So studies have shown that doctors from racial and ethnic backgrounds that are underrepresented in medicine are more likely to practice primary care than white physicians. And they're also more likely to practice in medically underserved areas or health professional shortage areas and rural areas. Unfortunately, though, the representation of racial and ethnic minority physicians among the primary care workforce remains low. And so we looked into some efforts to diversify the physician workforce as well. So a number of medical schools have attempted to increase the diversity in health profession schools by shifting to holistic admissions processes. This basically means looking at criteria beyond test scores and GPAs. And then many medical schools also implemented pipeline programs, which seek to intervene earlier in a student's career, targeting, supporting, recruiting middle school, high school, college students, and to bring them into the medical school applicant pools. With respect to holistic admissions processes, at least one study found that this did increase the diversity for most racial and ethnic groups, but not for Black students. The study expressed the need for earlier intervention to actually support people into making the decision to apply for medical school in the first place. So this brings us to pipeline programs that try to support STEM education. They encourage young students to participate in programs that get them interested in health professions, and then also kind of hold their hand as they go through the application process. A significant problem that many medical schools are involved in is that there's a significant lack of systemic evaluation of the impact of these programs. So there hasn't been many studies to fully evaluate how effective these pipeline programs have been, and there's no number specifically saying that, doing X kind of effort really, resulted in these many students being added to the workforce. But we have seen some strong anecdotal evidence suggesting that these pipeline programs can be effective when they're implemented with significant state and community support. So for example, between 1978 and 2011, the Urban Health Program at the University of Illinois at Chicago had the highest graduation rate for minority healthcare professionals in the country after historically Black colleges and universities. So this program was established and funded by the Illinois General Assembly in response to the efforts of civil rights era activists. And even today, it relies heavily on the involvement of local community to function and to kind of develop this program. And they've seen significant advances in the diversity of their physician workforce because of that. Next slide. A systematic review of 72 studies found that a variety of physician characteristics can impact their decision to practice in underserved areas. So of course there's race and ethnicity and being from a rural area, but then the review also found that there's a few other factors that end up weighing heavily. So first there's financial factors like debt and anticipated income. And then second, there is exposure to rotations and residency programs in underserved areas, which can also help these areas recruit and retain physicians. So HRSA does kind of has its foot in both these areas. So first, they provide loan repayment and scholarship scholarships directly to medical professionals. So some of the studies that looked into these programs found that the HRSA-run NHSC, which is the National Health Service Corps Scholarship and Loan Repayment Program, tended to be more successful when they were loan repayment programs that targeted physicians towards the end of their training. And they had a higher physician retention rate in underserved areas when they were targeting physicians at the end of their training, compared to service obligation programs like scholarships that target medical students earlier in their medical career. And then aside from these direct financial incentives to providers, HRSA also provides institutional grants like the Teaching Health Center. They administer the Teaching Health Center grant. There is strong evidence, for example, that the Teaching Health Centers attract students from residents from rural and disadvantaged backgrounds. The majority of the graduates of these teaching health center programs then end up practicing primary care in a HPSA as well. Next slide. So next we looked at foreign trained physicians. So research finds that foreign trained physicians are more likely to choose primary care residencies and practices than US trained physicians, and that more than half of all foreign trained physicians end up working in an area where the population has a per capita income of $30,000 or less. So many of these physicians, however, do face some burdensome visa requirements. So the federal government established this Conrad 30 program to waive some of these requirements, and each individual state can request up to 30 waivers from the federal government to meet their healthcare workforce needs. So the evidence shows that the Conrad 30 visa waiver program can bring primary care physicians to underserved areas, but its effects are definitely more pronounced in urban underserved areas. On the other hand, in rural areas, the state loan repayment programs and medical school rural track programs have both been shown to be more effective than this Conrad 30 program at retaining primary care physicians. Studies and case studies have suggested that cultural disconnect might be playing a role in the inability of rural areas to retain these foreign trained physicians. Next slide. So we also looked into evidence that shows that increasing the number of primary care NPs can expand access for underserved populations, particularly in rural areas. But nurse practitioners in various studies reported that scope of practice restrictions in several states were limiting their ability to admit and treat patients. Some states have eased their scope of practice restrictions to allow NPs to treat patients independently. And evidence does show that states that grant NPs this greater autonomy do experience an increase in the number of NPs totally, and an increase in healthcare utilization even amongst rural and other vulnerable populations. Another study showed that NPs were also more likely to work in primary care in states with relaxed scope of practice laws, and that these odds only increased further if the state paid NPs about the same Medicaid rate as physicians. Next slide. So shifting gears from workforce-related issues, the next category of initiatives kind of looks into the efforts to bring more safety net outpatient clinics closer to people in communities who need them. So as you must all be aware, the federal government creates and supports two key types of designated safety net primary care providers. You've got your FQHCs, the federally qualified health centers, and rural health clinics. Very briefly, FQHCs are required to offer care in medically underserved areas, regardless of insurance status or ability to pay. Rural health clinics were primarily designed to provide care to Medicare patients in rural areas, but many of them do see non-Medicare patients as well. Both FQHCs and rural health clinics receive enhanced payment for Medicare, Medicaid. And FQHCs receive further federal support in the form of grants as well. And according to some recent estimates, FQHCs see about 28 million people in rural health clinics, about 7 million. So there is significant evidence showing that both these kinds of health centers can really improve access to primary care. For example, both models provide appointments more quickly than independent physicians' practices. And then FQHCs tend to have a higher and they have a growing percentage of racial and ethnically diverse patients than private physicians' offices. But according to some recent estimates, there's still significant swaths of people who still don't have access to FQHCs or rural health clinics, about 17 million-ish people. Some recent studies have shown that newer FQHCs are less likely to be located in rural areas, high poverty areas, areas with a high percentage of minority residents. So while continued support for the expansion of FQHCs and rural health clinic models is essential to ensuring access to primary care for underserved populations, there is a question about whether current federal policy is sufficiently incentivizing new health centers to locate in areas with the greatest need. Next slide. So another type of safety net provider that we looked at were school-based health centers. School-based health centers provide access to primary care and other health services to about 10,600 schools and over 6.3 million students, and they predominantly serve rural and urban underserved communities. School-based health centers help children and their families overcome barriers like transportation, time, cost, and otherwise prevent them from receiving essential healthcare services. Extensive research links school-based health centers with healthy eating, active living, increased school attendance, improved health-related quality of life, and non-health related quality of life outcomes. Between 1999 and 2017, thanks to significant foundation funding, state funding, general expansion of federal support for federally qualified health centers, the number of school-based health centers basically doubled. The reason that support for FQHCs is important here is because half of the SBHCs are sponsored by federally qualified health centers. School-based health centers generally need a sponsoring organization, and those can be FQHCs, which are the most common. They can also be local hospitals, nonprofit organizations, local health departments, school districts. And one case study found that school-based health centers were more sustainable when they were sponsored by federally qualified health centers because of their ability to receive these enhanced Medicaid payments. But despite this like 2-decade expansion that we were talking about, the SBHC still only serve about 10% of US public schools. And there is limited literature on the ways that policymakers and communities can best support the expansion of this model. And some case studies do suggest that local leadership and community support is vital. Community support and trust tended to build more easily when the SBHC was staffed by people from the community, and when the sponsoring FQHC already had strong community ties before the creation of the school-based health center. Next slide. So now we can shift gears and talk about some initiatives that tackle structural barriers like lack of transportation or inability to take time off to attend mid-weekday appointments. So first, we'll look at telehealth. I mean, because of COVID-19 pandemic, we've seen significant increases in the use of telehealth, as well as policy changes loosening restrictions on telehealth and improving reimbursement for it. At the time we were compiling the research for this paper, not a lot of literature had been released on the effectiveness of specific telehealth modalities and expanding access, particularly when it comes to underserved populations. But early studies did show that while telehealth did generally improve access for some populations, it did leave behind a couple of specific types of vulnerable populations. The rural populations, older adults, those with lower socioeconomic status, limited health literacy, limited English proficiency, continue to face significant barriers. Most commonly, they are the lack of necessary technological devices like laptops or smartphones, limited digital literacy or comfort with these telehealth modalities, and finally, unreliable internet coverage. So during the pandemic, federal and state governments, as well as charitable foundations, hospital systems, have been funding efforts to specifically improve access to telehealth for underserved populations. So for example, one university hospital partnered with community and church leaders to introduce a telehealth tool to African-American patients in an urban underserved setting. A report found that it is key to tailor these telehealth technologies to the needs of specific underserved communities that they're trying to reach. But more evaluation of these efforts that's sprang forth during the COVID-19 pandemic is necessary to shed light on how to make telehealth more equitably accessible to underserved populations. Next slide. On transportation barriers was one of the things that came up most significantly during a lot of our case study interviews, and studies show that these barriers like unreliable public transportation, high cost of available transportation options, and insufficient disability accommodations can lead to rescheduled, missed appointments, delayed care, delayed medication use. Transportation barriers are also more likely to affect women, those experiencing poverty, those who have less education, older populations, and members of minority groups. So in order to combat these transportation barriers, it's worth noting that Medicaid itself offers non-emergency medical transportation, or NEMT, as a benefit to its enrollees. In its traditional form of the service, Medicaid sort of contracts with a transportation service provider. Enrollees need to book it ahead of time, and it takes them to their appointments. But significant studies out there show that this service is stringent. They have stringent state-specific limits on how it can be used. And studies show that the benefit, as it is provided traditionally through Medicaid, is nowhere near flexible enough to meet the needs of the enrollees. So some state Medicaid programs have been thinking outside the box and collaborating with ride-sharing services like Lyft and Uber to kind of fill in these gaps. Evidence suggests that collaborating with rideshare services can result in fewer missed primary care appointments, lower average wait times for transportation, and higher rates of on-time pickups compared to other types of NEMT services. But I will note that while more of the evidence suggests that these collaborations can help, at least one study found no improvement in appointment attendance even after provision of free rideshare-based NEMT. So maybe more research is necessary to kind of definitively say that this is helpful and this is the way that more people will end up overcoming the transportation barrier. And then finally, of course, for those who live in rural areas, rideshare services can be far more limited. That's not really an option. And so more efforts are needed to find better ways to improve non-emergency medical transportation for these populations. Next slide. So many patients, particularly those in low-wage industries, have trouble accessing primary care because of inflexible work schedules and a lack of paid leave. This prevents them from being able to see primary care clinicians during regular office hours. Without after-hours access to primary care clinicians, evidence shows that many patients are likely to overuse emergency departments. So in North Carolina, one Medicaid MCO provided 24 hours a day availability to primary care through the use of a call-and-nurse telephone system, and also convinced several practices to expand the numbers of Medicaid enrollees that they were accepting. The researchers evaluating these efforts found that that the MCA was able to reduce emergency department usage, and this can be seen as a proxy for improved access to primary care. On the other hand, some states like South Carolina and private insurers like United Healthcare offer additional reimbursement for after-hours care. However, the effectiveness of this measure in improving access to primary care has yet to be evaluated. And more work needs to be done to figure out how to better provide after-hours access to populations who cannot take the time off to see the doctor in the middle of the day. And with that, I'll pass you along to my colleague, Megan Houston, to talk to you about affordability of primary care issues, initiatives that improve trust and communication between providers and the community, and finally, to give you some highlights from our case studies. Thank you.
Hi, everyone. So I will take over from here. As Maanasa said, I'm Megan Houston. I'm a research fellow at Georgetown's Center on Health Insurance Reforms. So in terms of affordability, this is another key element of access that we focused on, especially as a lot of our research is focused on health insurance. So the first sort of initiative in this category we focused on was programs that or policies that try and remove cost-sharing barriers to primary care. And so we looked at value-based insurance design, which is, for those of you that don't know, I'm sure most of you do, is just a benefit design that tries to steer patients towards more high value kinds of care based on the cost sharing and other different benefit design elements. And so several large employers have instituted these types of programs, as well as some state Medicaid plans and Medicare Advantage programs have done this as well in an effort to boost use of primary care. And the evidence has showed that enrollment in these types of plans is associated with an increase in utilization for primary care visits, as well as a reduced reduced hospitalization and inappropriate ER visits, which is also, as Maanasa just mentioned, sometimes used as a proxy for measuring primary care access. If you're not going to the hospital, theoretically, you're getting some good preventive care. However, despite this positive evidence, there are some barriers in terms of just instituting these programs. They can be administratively burdensome, especially for maybe a smaller employer or a smaller health plan that doesn't have this type of benefit design, and trying to tailor it to a certain population can be challenging. And sometimes there can be enrollee pushback to these kinds of programs. You can go to the next slide. And then the second category, or the second initiative under this category of access we looked at, was network adequacy. And again, I'm sure you're all familiar with this, but for those who aren't, network adequacy laws and regulations basically impose requirements on health plans to make sure that their products include a wide variety and sufficient numbers of different types of providers so patients and plan members can meet their health needs. And they definitely vary by market and by state, but Medicare Advantage, Medicaid, managed care plans, and marketplace plans all have different forms of network adequacy that they are supposed to follow. However, from our research, we did not find a ton of evidence that the network adequacy laws that are currently in place are doing a lot in terms of access to primary care. And we were looking specifically for primary care evidence. I think it's possible there's some evidence that has improved access to other kinds of specialties, especially specialties that may be harder to reach or more higher, maybe different kinds of shortages. But for primary care, we did not find a ton of evidence that it's doing a lot for access in these different settings. And we even found that there is still some disparities, racial and ethnic disparities, when it comes to different kinds of networks. So there's some harder access for racial and ethnic minorities in gaining access to wide networks in Medicare Advantage, for example. And there was also some research, a recent few years ago report from the Office of the Inspector General raising concerns about how effective the network adequacy standards are working for Medicaid managed care, and are people truly able to be accessing what they need under these regulations. You can go to the next slide. So shifting gears from affordability, as Maanasa mentioned, acceptability is sort of our last category of access. And this is, I would say, one of the most challenging ones to try and overcome, just because it is, a lot of it comes from outside the healthcare system. It's very structurally determined and can be really challenging to overcome. But we focused first on an initiative of building cultural competency in the healthcare workforce. So specifically, requiring cultural competency training for providers and their staff, trying to get people to have a better sense of social determinants of health, as well as the cultural needs of a community that providers may be serving. And from what we found, that these types of initiatives are sort of sporadic and have not been implemented consistently, and there have not been a lot of great evaluations of these efforts or what their impacts may be. So we really wanted to highlight this more as an area really with a lot of opportunities for research and opportunities to learn, because there could be a lot of work to be done here when it comes to acceptability of care and overcoming mistrust in medicine. You can go to the next slide. And then another intervention in this category we looked at were community health workers, and specifically integrating those workers into primary care delivery. So we found significant evidence just looking at community health workers and how they can help build trust in communities with patients. They often serve as liaisons between patients and their providers, or patients in a facility, or even just trying to talk about health and educate just health on health literacy. And some states have passed laws that sort of more substantially regulate and authorize community health workers to be certified or licensed. And some places, community health workers can actually bill Medicaid, which can create more of a sustainable path for their work to be included in practice. But we have not seen, despite some increase in reimbursement, we have not seen the growth in the number of community health workers that I think maybe would match the need that is out there for this type of work. And I think that there is also, from what we found, not just in our initial research, but also from our case study interviews, it seems like there's sort of a lack of awareness. So it's sort of like there's not a lot of laws and regulations out there about them. And as a result, they are not super well known. And so it's sort of a cycle. So I think trying to increase awareness of how these types of providers have really helped sort of bridge the gap in access and mistrust and just understanding how to manage your care. So all in all, more research is needed, I think, to evaluate better ways to support community health worker integration, because the little evidence we have seen has shown great promise, but there's just a lack of funding there and a lack of awareness to initiate those kinds of interventions at this point. You can go to the next slide. So I'll just briefly go through what we've been working on with our case studies for our presentation, for the remainder of the presentation. So our first location that we started was in Grant County, New Mexico. And that is, for those who don't know, is in the Southwest New Mexico. And it is a very rural population. You can kind of look at the demographics here and see it's certainly a high need area in terms of primary care. And we chose this location, we're trying to get a variety here in terms of, geographic diversity across the country, as well as rural, urban, all these different things to try and get a wide variety of views. But we did find some national reporting about this county on successes they've had in primary care access. And that's sort of what led us here. So you can go to the next slide. So after talking with stakeholders in Grant County, we had a few sort of key takeaways in terms of what is working there. And so one of the main reasons they've had success is because just right off the bat, they have a lot more folks insured than even neighboring rural counties. And I think primarily because they have a lot of people who are employed by employers who provide insurance, and even the types that may not typically always provide insurance. And so there was a lot of union jobs, there's a lot of public employment that really boosted the insured rate. And as well as the state itself, New Mexico expanded Medicaid, which also has played a huge role in folks being able to access primary care because they have that coverage, that baseline coverage. And then the third sort of key finding in terms of what's working there and what's leading to success in access is the federally qualified health center in that area is very robust, and everyone in the community has really worked together to boost it up and keep it going. And it has, behind almost every intervention we looked at, they played a role. So I think this was a great example of how FQHCs can be a huge builder, not just in directly accessing primary care, but all other things. So you can go to the next slide and so it's called Hidalgo Medical Services, and they have a number of different facilities. They provide a lot of different services: primary care, dental, mental health care. And as I think earlier in the presentation, Maanasa went over sort of how FQHCs have not been always distributed in the areas that are high need. There's a lot of complications when developing new FQHC sites, but Hidalgo Medical Services has really worked to, when they are making expansions, to target areas in need, not just for health status reasons, but maybe they're distance to a healthcare provider, or any number of factors. And as most FQHCs do, they also really work to address social determinants of health, which is a critical component, especially for folks who are experiencing chronic disease. And another really interesting thing that they did was, they're providing direct health primary care services to folks in the community, but they're also really active in recruiting and working to retain their primary care and just health care workforce. And so they run a successful primary care residency program, which has worked really hard to recruit folks who are interested in serving rural populations. They've leveraged federal funding to build a clinic that provides housing to residents on their top floor. So it really is an attractive element for physicians in training. And they also work with local students even before medical school, before college, to try and increase interest in the local community in health professions, because, as Maanasa was saying, there's a lot of evidence to show, when you are trying to recruit folks to work in a community, it is a lot more effective to have them actually be people who are from that community, who would be likely to return and stay after they finish their medical training. So you can go to the next slide. So they have had a lot of successes, but as unsurprising, they also had a number of challenges when it came to primary care access. And so even though I just spoke about their great successes in terms of recruiting and retaining physicians, they did definitely identify that it has not been an easy path. And so trying to attract and maintain physicians coming from other places, they've said, has been hard. There's often a lack of job opportunities, maybe for the family members that may be moving with a physician they're trying to recruit. And I think that there's just like a challenge to try and retain folks once they get here. And then as we were just hearing about, transportation is another big challenge, and certainly in rural communities can be uniquely challenging, not just because of the lack of public transportation or lack of reliable or consistent public transportation, but also, ride sharing companies are not always, there's not always as many drivers out there. And so I think that definitely is a key issue in Grant County that they are working to fix. But, it all comes down to having enough sort of political will as well as funding to try and implement programs that are effective. And transportation is no exception to that. Another issue we heard about earlier, which was certainly one for Grant County, was internet access. So telehealth was obviously majorly expanded after the pandemic began because people wanted to access care remotely. But because of broadband access limits in the community, it was hard. A lot of them, thanks to the flexibilities and reimbursement at the beginning of the pandemic, they were able to do care on the phone when needed, if they just needed to discuss an issue with a provider. But I think that's certainly something that needs some major interventions in terms of majorly expanding broadband access. And then also in terms of community health workers, there were some successes there in terms of their work helping patients sort of understand their care, but there is no Medicaid reimbursement. So I think some of the programs we spoke to, they had some private funding. I think that I can't remember if it was in Grant County or another location. There was one private payer that had a pilot program, I think, where they were paying for community health workers, but certainly, it was without sustainable funding. It's hard to make these types of staff stay for long term. And then also the local leaders identified challenges collaborating on population health needs, which I think kind of speaks to a broader issue in our country with a lack of investment in public health. So certainly a number of challenges, but it was a great place to start because they really touched on a lot of the issues that we found in our research. You can go to the next slide. So our second case study was a very different location demographically. It was an urban setting close by to where we are in Washington, D.C., Baltimore. And, you know, we wanted to shift gears to a place that similarly had challenges with primary care access, but also, you know, they have Johns Hopkins University. They have a lot of folks who are studying this and interested in trying to improve access to primary care and healthcare generally. And so they were a great sort of first urban setting for our case studies. You can go to the next slide. So in Baltimore, kind of overview here of what we found. A lot of folks we spoke to identified a shortage of primary care providers that accept Medicaid and treat lower income residents. And so, you know, the state of Maryland expanded Medicaid. There is a decent amount of folks who are insured, but Medicaid enrollees have experienced very high wait times to access primary care. So, you know, another good example of just because you're insured and just because you have a plan doesn't necessarily translate directly to increased access to care. And I think similarly, you know, a shortage of non-physicians like PAs and RNs, as well as staff, which has made it challenging for them to sustain the amount of patients that are in need. And then also FQHCs in Baltimore, similar to Grant County, were a key access tool for patients in Baltimore. And they actually provide care to 65% of the residents in Baltimore that are at or below 200% of the federal poverty level. And so huge source of care for low income people, as is in many parts of the US FQHCs. And then we did find some success with physician recruitment and retention programs, but it doesn't appear to be meeting the need. And so providers in, you know, loan repayment programs, they really only make up 5 to 10% of the providers in the area. And there weren't a lot of data on whether providers continue to serve after the program is over. And then, as I mentioned, you know, the state expanded Medicaid. They also have done a lot to try and increase access to private insurance on the marketplace. They have a lot of, they have some state funded premium subsidies and easy enrollment programs to make sure people stay enrolled. And as we heard about earlier, school-based health centers are a huge valuable resource for, you know, kids to access care, but these programs have stalled because of a lack of a lack of funding in Baltimore, as well as some administrative barriers to implementation. So the funding has increased in the past few years, but it's still not enough to meet the need. You can go to the next slide. Great, yeah, so our last case study, as Maanasa mentioned, will be in Columbia County, Arkansas. We are just in the beginning stages of interviewing folks there. If anyone, just to echo what Maanasa said, is interested in collaborating or has questions, or maybe folks we might or should talk to, definitely let us know. You can go to the next slide. I think our emails are on there. Yes, so yeah, just thank you so much, everyone, for your interest. Excited to hear your questions.
Thank you, Megan. And I know we've run pretty close to the hour and run over our time, but if there's any questions, we're happy to stay another couple minutes to answer them.
I just want to, hi, this is Palmier Cares from Rhode Island. I just want to say this is like really comprehensive and great work. And specifically, we've done a lot of work in Rhode Island around community health worker engagement, both in community health teams, but now it's paid for by Medicaid, and trying to look at in practices. Many of the FQHCs have already adopted, but non-FQHCs as well. And love to see about working with you in the future, at least collaborating to see how we can improve that, our work, and you might find something interesting to study.
Oh, absolutely. Thank you.
Just a comment about what we've done in Arkansas. If
is that Bill? Do you want to introduce yourself real quick?
Oh, Bill Golden. I'm Arkansas Medicaid We have a very active medical home program. We have a lot of, we have about over 200 private practice sites, 1,000 docs. And one of the things we did about access to care is that we've basically required that you can't use answering machines at nights and weekends. Essentially, the practices are providing 24/7 live voice access to care. And the last secretary report about ER use, Arkansas had one of the lower or lowest emergency room use per capita of all the surrounding states. So I looked into that, but requiring or getting rid of answering machines is a major way of improving access to care at night and on weekends.
Oh, it's great to hear. And as we mentioned, we've been looking to interview people in Arkansas. So if you would be interested in talking to us about these efforts of the PCMH program, which has definitely been on our minds, we'd love to chat with you outside of this.
Yeah, you can talk to me or talk to Larry Ballard at Medicaid. We're in our 10th year, and we have 85% of the eligible patients in the medical home right now.
Yep, thank you.
So there's another question. How are the practices staffing the 24-hour services? So I guess that's a direct question. That's a kind of an Arkansas specific question. So why don't you guys take that one offline?
Well, it's no big deal. They don't get that many calls if they run their practice.
Oh, okay. Well, there's that. Right. Thanks. All right. Looking to see other.
Hey, this is Brian Frank. I'm in Portland, Oregon, and at QHC. I'm specifically interested in the intersection of business and caring for lower income individuals. You mentioned, especially in New Mexico, that there was a benefit seen from having employee benefits. I guess I'm wondering, have you explored at all the incentive for businesses to be more involved in this space for either increasing access to healthcare or helping their employees meet their social needs?
So actually, this is a little bit related to a different project. We looked at state employee health plans and their involvement in primary care and like trying to improve access to that. We find that employers do provide some benefits like worksite clinics, and obviously that doesn't mean much in the era of telework for most people. But we have seen some efforts to work with their TPAs. But I think a lot of the times we've found that they are very much beholden to whatever ideas the TPAs put in front of them. And I don't know that much is emerging from the employer side directly. And that, the level of effort that various TPAs put into developing primary care access programs is obviously varied and across the board. So we didn't specifically look into employer-based initiatives for this project, but I think that some of the teachings from our state employee health plan project do kind of apply, and that we think that employers could do more, but they're kind of more reliant on their TPAs to kind of develop those programs.
Okay, great. Maybe I'll try and connect with you offline. I'm getting ready to start a pilot of offering community health worker services as an employee benefit rather than through FQHCs.
Oh, absolutely. We'd love to connect on that. Yeah.
Okay, great. Thanks.
Terrific. We are really kind of run over on our time at this point. So I'm looking to see if there's any other questions per se. You have the contact information. I'd like to say thank you to Maanasa and Megan for the wonderful presentation. If you think that's comprehensive, you should be reading the extra reports because they're very detailed, and it's just a great overview that we have here. So on behalf of our group here, thank you to our presenters. Thank you on behalf of Milbank to all of you who participated today. And I think we will come to a close.
Thank you.